So last chapter for this summer, and the peripheral nervous system is naturally a little bit simpler than the central nervous system, as are injuries and conditions of the peripheral nervous system. However, we do see them a lot. So it's we're just gonna this is our little brief introduction, and then we'll talk more about that in future classes. So we're going to talk a little bit about the peripheral nervous system organization in contrast with the central nervous system. So the peripheral nervous system is anything that's outside the bone. So it's not inside the spine, that's the spinal cord. It's not inside the cranium, that's the brain. Everything else is peripheral. So when we talk about dermatomes and myotomes, it's the skin and muscle that's innervated by the peripheral nervous system. We're going to talk about classifications of peripheral nervous system injuries, key peripheral nervous system disorders by category, some of the etiology and progression and prognosis, and our role in the management of these types of injuries. So the peripheral nervous system components include somatic, motor, and sensory components of cranial and spinal nerves. The cell bodies are located in the brainstem, spinal cord, or dorsal root ganglia of the spinal cord. And the autonomic system nervous fibers are part of the peripheral nervous system as well. So the peripheral nervous system is outside the brain and spinal cord, like I said, can regenerate on a limited basis, but central nervous system has very, very, very limited regeneration. And in clinical neurology, we'll talk about why that is. Sensation and movement are affected by the peripheral nervous system, and as well as autonomic functions. So all the automatic stuff that's going on in the background. Central nervous system is the brain and spinal cord, very limited regeneration of cells in this area, complex integration, and it's encased in bone. So I always say the most important things in the body are encased in bone. This includes the central nervous system. Not that the peripheral nervous system isn't important, because it is. So a lot of times injuries are classified by the distribution of the injury. So how many, either by the nerves affected or by the pattern or categories of dysfunction. So if there's a single peripheral nerve affected, it's considered a mononeuropathy. So carpal tunnel syndrome is a classic one of that. It's the median nerve is compressed in the carpal tunnel and a single nerve is affected. Polyneuropathy, several nerves involved. You can have symmetrical polyneuropathies, or you can have asymmetrical polyneuropathies. Usually symmetrical polyneuropathies are due to metabolic disorders like diabetes. Radiculoneuropathy is where there's a nerve root involved as it emerges from the spinal cord and it radiates. One nerve radiates down that peripheral nerve pathway. Polyradiculitis is several nerve roots involved, and that usually has to do with an infection. Myopathy is where muscle tissue gets in on it. So there's muscle involved. So you can have sensory loss following a nerve distribution, a peripheral nerve distribution, or a dermatomal pattern. You can have motor loss that affects muscles innervated by a particular nerve distal to the lesion. So you'll have the loss in a myotomal pattern. You can have a spinal nerve lesion, and spinal nerve lesions give you weakness in a myotomal pattern as well. So four main categories of peripheral nervous system dysfunction include hereditary, mechanical, metabolic, and infectious. So an example of a hereditary peripheral nerve dysfunction is Charcot-Marie-Tooth disease. So Charcot was a French neurologist in the 1800s, and a lot of neurological diseases are named after him because he's the first one that identified him. But Charcot-Marie-Tooth, also called CMT, was identified by him and two other people, and that's why it's called that. It's a genetic disorder. It's a recessive. There are a lot of variants, so some of them are recessive, some of them are dominant, and some of them are X-linked. It's usually becomes more apparent in adolescence. And some you get demyelinated axons causing weakness and impaired sensation, and others you get axonal degeneration, depending on what variant it is. So the muscle involvement pattern is it affects the fibular muscles or the peroneal muscles, if you want to go old school, first. Then it affects the anterior and posterior tibialis. Then it affects the gastroc and soleus in the lower extremity. In the upper extremity, um, it goes proximal to distal. So it's interesting in the lower extremity, it doesn't really go proximal to distal. It in fact affects just certain groups. So the anterior muscles, I mean the lateral muscles, the anterior muscles, and then the posterior muscles. So it's really kind of interesting. So you get severe hand clawing sometimes and like foot clawing. They don't call it clawing with foot, but it's that same kind of exaggerated arch. So the clinical presentation is you get atrophy and weakness in the lower legs. And as the disease progresses, you get into the hand. Numbness, tingling, and pain in the distal periphery. Cavus foot, which is the really high arch with hammer toes, and that's like the clawing of the foot that I was talking about. You also get drop foot and a high steppage gait where people really bring their knee up so they can clear the toe because the tibialis anterior can't lift their foot up. So the PTA role in CMT management, and I have worked with a few people with CMT, you want to be able to maintain muscle endurance and strength. Joint range of motion and stretching is really important. Balance training and fall prevention, assistive devices and orthotic fitting, and gait training. So most people who have a hereditary disease like this, they've sort of been dealing with it for a long time, and they want you to tweak their program. So that's good. We can do that. Mechanical injuries can involve compression, traction, entrapment, or inflammation. So the four key conditions that are considered mechanical, there are other ones, of course, but these are the ones you see more often: radial nerve palsy, carpal tunnel syndrome, Bell's palsy, and sciatica. So radial nerve palsy, sometimes they call it Saturday night palsy or honeymooner's palsy because it's like your arm goes numb from trying to sleep with your arm around another person. That's why they call it honeymooner's palsy. So it's radial nerve compression, basically. Carpal tunnel syndrome is median nerve compression. Bell's palsy involves the cranial nerve 7, the facial nerve. And sciatica is radiculopathy from the lumbar area that goes down the back of the leg out to the big toe sometimes. Um, so compression is sustained pressure on the nerve. So carpal tunnel syndrome and radial nerve palsy involve compression. Traction, radial nerve palsy can have a little bit of a traction component to it, as can sciatica. Entrapment, nerve caught in a tight anatomical space. So that sciatica can be that from degenerative disc disease. And inflammation, swelling reduces the available space, and you get that mechanical pressure. So with tunnel syndrome, sometimes you have some inflammation in there that is adding to the compression. And you get a breakdown of the myelin on the nerve. So metabolic neuropathies, the two main ones are diabetic neuropathy that results from poor glucose control and small nerve oxygenation. Can't say that. And alcoholic neuropathy due to chronic alcoholism and nutrient deficiency. So they have common characteristics, even though they have different causes. They both have polyneuropathy, so it affects multiple nerves. It occurs in what they call a stocking glove pattern, where the distal involvement first, so like a glove or a stocking, and there's symmetrical sensory and motor changes. They both include demyelinization and axonal degeneration, and both are progressive if the underlying cause isn't addressed. Diabetic polyneuropathy is preventable through controlling your glucose fluctuations. Alcoholic polyneuropathy is reversible with abstinence if it's caught early enough. So that's good. Guillain-Barré syndrome is an acute inflammatory demyelinating neuropathy. So we talked about MS as being a central nervous system um, inflammatory demyelinating neuropathy or inflammatory demyelinating disease. Guillain-Barré is like the peripheral version. The pathophysiology isn't completely clear on, it's not completely known, but it is an autoimmune reaction and it can be triggered by a viral infection, post-surgically, or sometimes a reaction to a vaccination. And the immune system decides that it doesn't like the myelin anymore and it attacks it, mistaking it for a pathogen's proteins. So the onset can be hours to weeks. The recovery can be weeks to months and sometimes years. Most patients fully recover. There's less than 10% mortality. And when people die from it, it's because their C4 nerve is affected, and that innervates the diaphragm, so breathing. So people that have that C4 involvement often have to be on a ventilator in the acute phase. I've worked with lots of people. Well, I don't know if lots is the right word. I've worked with many people, Guillain-Barré, and most of them have had either full or nearly full recovery. And nothing I love more than running into somebody that I worked with years ago with Guillain-Barré at the ski area or in a walkathon or at a dance class. So that's just great stuff right there. Um, Most patients regain muscle strength, sensation, and pre-disease activity levels. Some patients continue to have pain, weakness, and abnormal sensations. Older patients or people with a longer acute phase have poorer outcomes. And I have seen people who had some secondary issues which extended their recovery. Um, and they eventually recovered, but older patients definitely have poorer outcomes and people that were longer in the acute phase. So we're going to do muscle strengthening, endurance training, gait training, splints and orthotics, assistive device training, and help return to functional activities. All the stuff we're good at, right? Um, you definitely, especially if you're working in the acute care, you want to monitor for respiratory compromise. In outpatient, that's not usually, they're usually past that, but you still want to monitor that. You want to be aware of autonomic instability. So they might have orthostatic hypotension, or they might have trouble controlling their temperature because of the effects on the autonomic nerves. You should progress activities gradually, focus on functional recovery and emotional support because it can be scary. They think they're never going to get better, but they are. And so that support can be really important to them. Overall, in peripheral nervous system disorders, we are always working on movement and mobility, range of motion, stretching what's tight, strengthening what's weak. Gait training, balance training, assistive device, orthotic fitting, ADL training, fall prevention, and activity modification, all those things we're working on with most people, and we are working on them also with people with peripheral nervous system disorders. So condition-specific considerations for Charcot-Marie-Tooth, long-term management because it's a progressive condition, radial palsy, splinting and nerve glides and things like that. It's a temporary condition. It goes away. It's the good thing. Bell's palsy, I've never worked with someone with Bell's palsy, but facial exercises and sometimes electrical stimulation. It would be interesting. I would love to work with someone with Bell's palsy, but I never have. Carpal tunnel syndrome, neutral positioning, activity modification. A lot of times we see people post-surgically for carpal tunnel. I've had good luck with instrument-assisted soft tissue mobilization on the transverse carpal ligament. Each person's going to be a little different. Sciatica, movement-specific exercises and avoiding aggravating movements. Diabetic polyneuropathy, prevention education, and wound care. and education about inspecting feet and areas where you can't see. Um, Alcoholic polyneuropathy, being supportive of lifestyle changes, and Guillain-Barré, monitoring for complications and progressive training. So we want to look for respiratory changes as red flags, autonomic instability, so orthostatic hypotension or temperature regulation issues, skin breakdown for people who are diabetic, but for anybody, skin breakdown, rapid progression or new neurological symptoms, um, things that indicate progress, strength improvements, sensory return, functional improvements, pain reduction, balance improvements, running into people at a dance class. That's a good indicator of improvement. So I like working with people with GBS. It's really fun because they have a good recovery. We're going to document functional outcomes. What can they do now that they couldn't do 2 months ago or a week ago or last week? Um, Safety concern. Well, for objective measures, we're going to measure strength. We're going to measure range of motion. We're going to do balance testing, functional balance testing. We're going to be concerned about fall risk and skin integrity. Does the patient understand what we taught them? Sometimes the teach and teach back is a good technique. And do they have any equipment needs, assistive devices, or orthotics? Someone with GBS, they're going to be getting better and better. And so they're going to progress out of their assistive devices and you're going to help them with what they need next. So always report changes in neurological status or unexpected responses to treatment or patient concerns about symptoms to the primary PT.